Dr. Moore, I'd asked you before we broke up about the introduction of anti-HCV screening in 1991. And I'd just ask you briefly about surrogate testing, so using either ALT testing or anti-HBC testing to detect surrogate markers of non-A, non-B hepatitis. Again, is it right to understand that you were not closely involved with consideration of that issue during your time at the Department of Health?
That's absolutely right, yes.
Now, there are a handful of documents into which you're copied or minutes that you attend where the issues discussed. I actually only want to ask you about one of them and see whether you can help us with that. It's BPLL 0007202. This is a meeting of the Advisory Committee of the National Blood Transfusion Service, 17th of June. The date doesn't appear, but it's my understanding it's 1987. And we can see that you're in attendance as part of the DHSS Secretariat. If we go to page 4, there's a discussion about ALT testing. The heading is just above paragraph 30. The chairman asked whether the committee agreed with the Lancet article concluding surrogate tests for hepatitis could not be justified. Dr. Cash said that Scottish directors were proposing to establish such tests in view of impending product liability legislation in 1988. There was also clear indication that the private sector would test and they did not wish to fall behind. Dr. Smithers advised that there was a research proposal which aimed to establish the need to run surrogate tests for non-A, non-B hepatitis. It would look at the effect of infected donations on recipients. There was insufficient evidence of non-A, non-B after the HIV deferral of donors had been introduced. It was therefore now even less cost-effective. Dr. Gunson considered that introduction would be premature, causing an unjustified loss to panels. Dr. Forrester gave an assurance there'd be no decision until research had been carried out. The chairman summarised the views. If testing was introduced, it should be national. He noted that research on baseline data would be carried out. The position would be monitored here and abroad. Now, I just really have 2 or 3 questions arising out of that discussion and anything more broadly you can recall about the issue. First of all, just picking up paragraph 35 where it says the position would be monitored here and abroad. Was that monitoring part of your responsibility at HS1A in the Department of Health, or was that something which you understood was going to be undertaken by Dr. Gunson or the regional transfusion directors?
Yeah, it certainly wasn't my responsibility. Dr. Gunson or transfusion directors in discussion with Dr. Smithers, probably.
And then we see in paragraph 32, which records the views of Dr. Smithers, reference to surrogate testing being now even less cost-effective. Do you recall any particular discussions about the cost-effectiveness or otherwise of surrogate testing?
Not once I can put them into a time frame, but I do know that the view was that ALT testing was likely to throw up a lot of false positives, if you like, and that they would be detrimental to the panel, as it says here. And therefore it simply wasn't worth doing. I mean, that's just in broad general terms all that I was aware of, I think.
It might be said, looking at this discussion and the various different reasons that are given or concerns that are expressed and the suggestion for future research, might be said that didn't appear to be any great urgency to the matter from the perspective of those who were deliberating upon it. Is that something you feel able to comment on?
I think that's, from my point of view, as I said earlier, my concern in that 4 years when I was there was definitely regarding HIV rather than Hep C, non-A, non-B. We were aware of it as a problem. It wasn't top of my agenda. That's not to say that transfusion directors didn't have it on their agenda, because I know they did, but at a time when it didn't seem possible to do that much about it, and the papers that we'd seen on ALT testing did seem to suggest that really, given the population that we had in this country, that it wasn't worth doing. I mean, we were aware that people were doing it in other countries, but the suggestion was that our population actually didn't have as much non-anal BIHCV as other countries at that time. But really, I was only very, very peripheral to this.
Then move on to some views expressed by Dr. Gunson about achievements of the National Directorate. So if we look at NHBT 5028, we can see this is 50 years of blood transfusion, a document authored by Dr. Gunson with Dr. Dodsworth. If we turn to page 80, well, actually we start page 79, we can see this is the chapter entitled The National Directorate, 1988 to 1993. And then if we go over the page, we can see Dr. Gunson's account of what he described as achievements of the National Directorate. He said this: "It's important to remember that the National Directorate had no executive authority with respect to the RTCs, as they continue to be regionally managed. Its success in changing policies were achieved by persuading the senior management in RTCs that change was beneficial for the good of the service." And then he discusses a range of different measures. I want to ask you just about a couple of them. Interregional transfer of blood. That was, I think, something that, I'm right in understanding that you had direct involvement with.
That's right, yes.
So this was one of the measures which you sought to implement. It was an attempt on a national level to enable transfer of blood between centres, is that correct?
That's right. I mean, there was a certain seasonality attached to the blood supply. Times of holidays, Christmas, summer, and so on. Some regions could get low, or a region might have a call on a particular blood group if there'd been a major incident requiring untoward amounts. So the way we ran this, every morning, each transfusion centre faxed us their blood stocks, so we kept a national inventory, so that if any region was running out, they could simply phone the Directorate and we would arrange for a transfer of blood to them from elsewhere in the country. And that also included Scotland. Scotland were in that as well.
Now the next heading, the Management Information System, I'm not proposing to ask you anything further about that. If we go to the next page, Quality Assurance, page 81. That's it. So Quality Assurance, and Dr. Gunson here describes some of the measures that were implemented, including your proposal for there being a residential course for QA managers and so on. To what extent did considerations of the safety of the blood supply, and in particular safety in terms of potential for viral infections being transmitted, form part of either the quality assurance process or indeed any other priority of the National Directorate?
Right. The testing protocols for blood, and therefore the safety of blood, in terms of its viral loading, was set out in the NIBSC NBTS Red Book, which gave the specifications, if you like, for the products and the testing regimes that they should undergo. And that was, I say, it was written by NBTS in a collaboration with National Institute of Biological Standards and Control. So that was our gospel. Now, that was the recipe. The quality system was on top of that to ensure that what we set out to make, we could actually make. So the responsibility of the Directorate, because the Red Book, the NIBSC MBTS guidelines already existed before the Directorate was established, I think, almost contemporaneously with the establishment of the Directorate in 1989. The quality system was actually an initiative that I ran with, because I'd done that previously when I was in the supply division with orthopaedic implants. So the principles of quality systems were directly transferable. So that was written in to the first chapter of the NIBSC MBTS guidelines. The Red Book dealt with the quality system, and that was absolutely a National Directorate initiative. So one of the first strands of that was that there should be quality managers at each transfusion centre with responsibility for quality, and this refers to the fact that we had training courses for these QA managers. I was responsible for the appointment of them and the training of them, and then we organised quality audits where we would have small teams either led by Dr. Gunsel or myself and a couple of QA managers from the regions, and we would audit other RTCs. So there was a cross-fertilisation of ideas. Now, I mean, the whole system was directly supportive of product quality and safety, because we needed to, at that time, we needed to get licenses from the Medical Control Agency for the blood and products that we were issuing, and they were obviously insistent that we had a sufficiently good quality regime to support what we were doing. So the understanding of the quality system is it's not sufficient just to have a regime of testing. You need to absolutely ensure that testing actually happens, and all the factors that go into testing. So it's things like the training of the staff who do the testing, the checking of the temperature of the ovens, the speed of the centrifuges, where do you get your reagents from, the buildings, the labelling, the record keeping. All of that is built into the quality system, and the quality system is actually what goes to making blood safe.
So some of the issues I've been asking you about testing, whether it's surrogate testing or anti-HCV screening, the question of introducing such tests to improve the safety of the blood supply really are separate from the quality assurance system that you were introducing, because the National Directorate viewed those essentially as decisions for the Department of Health. The interrelationship comes with ensuring that if those tests are introduced, that they're done properly.
Absolutely.
Oversimplified way of putting it.
No, that's absolutely right, yeah.
If we go over the page then to page 82, the next heading is in relation to blood donor retention and recruitment. We've touched on this already with the replacement of the DHSS subcommittee with the new, I think, POD committee that was chaired by you. Again, I'm not going to ask you to go into the details of all the different initiatives, but broadly speaking, what was done in terms of retention and recruitment under the National Directorate that was different from or more extensive than that which was done prior to the National Directorate's establishment?
Okay, well, if I could just, I would like to just acknowledge the fact that the transfusion service was and is totally reliant on blood donors. We can't ever take them for granted. What was done differently was that we focused our advertising in a way that would actually, I think, appeal to donors. We did a market research study, you could call it, to try and understand the people that we were actually trying to recruit. And I think it changed the slant of our advertising. We'd had pictures of blood bags and bottles of blood bags saying, we need 10,000 units a day. Now, that's actually not going to appeal to anybody because people can only give 1 unit. It doesn't mean anything. We learned from our study to actually focus advertising to link the donor with the recipient, to help them realise that there was a real need for their gift and therefore be prompted to give. And there are 2 examples in this picture. Be a lifesaver. Could you find it in you to save her life with a picture of a baby? A direct appeal to the blood donor. And so that was the primary recruitment. We were much better at handling PR, national PR magazines, radio and TV. I was pretty much the focus for that nationally, and then the regional donor organisers would do exactly the same job locally on their patch, and we could knit the whole thing together, and that certainly hadn't been done before. We recognised the importance of retaining donors because the study showed that 27% of the population had actually given blood at one time or another. So that showed that the willingness was there to give blood. So we needed to find out, well, why did you stop? What do we have to do to get you back or to keep you? Because there were actually at the time only about 4 or 5% of the population was still giving blood. So that gave us an opportunity to make sure that the way we treated donors at transfusion centres or all our recruitment material was actually more focused on the donor and their expectations. I mean, we found some wonderful things. We found that the National Blood Transfusion Service was really very well recognised. The logo was sort of almost one of the top recognised logos in the country, the Twin Hearts, and that donors were well thought of. You know, a list of people who might be sort of worthy of being donors. It was really it really showed that donors were highly thought of by the rest of the population. So it was something that people wanted to be themselves. I mean, it was that kind of understanding in more depth than we'd ever had before. And in fact, that paper, it's cited quite widely.
And I think that's the paper that's written up by you in Transfusion Medicine, which we don't need to look at it, but the reference to the transcript is RLIT 000793. I think there might be a 0 missing there, 4 zeros. Dr. Moore, recognising, as you've already told us, that your involvement in decision-making about the introduction of testing, surrogate anti-HCV, was relatively limited, can I just explore one matter with you as a matter of really general principle? We saw from the minutes of that meeting that we looked at, the advisory committee meeting, a concern being expressed that the introduction of ALT testing might lead to a loss of donors. And a loss of donors might be a bad thing in crude terms for the blood transfusion service because there might not then be enough blood. Do you... First of all, would you accept as a matter of general principle, general common sense or logic, that there might be ways of making up for a potential loss of donors through testing by precisely the kind of strategies and initiatives and recruitment drives that you've described being introduced at a later stage?
Yeah, absolutely. And I certainly think that it could have been made up. I think the difficulty was the number of false positives, the number of people donors who've come along to do their bit and then get pulled out and it's suggested to them there's something wrong with their liver function or whatever, and maybe they have to go further and have biopsies on all the sort for nothing, because the test is not a good marker or it's a false positive. And some of the early numbers were talking like 3,000 people, 3,000 false positives. If you actually work it out, to actually counsel 3,000 people is 2 consultants full time for a year, because you've got to give them probably an hour each, because you're telling them something that might be pretty significant to their health. Now, if that's fine, if they've actually do have a condition, then of course it's well worth doing, and of course they can be lost as a blood donor. But if it's not right, if it is a false positive, then that is worrying. And I think that was a lot of the concern about some of those early tests or surrogate testing.
And then just still on the topic of recruitment and appeals for donations, and the study you've referred to, the article in Transfusion Medicine, recorded one particularly successful national appeal in relation to a national event, or indeed international event, Gulf War, that led to a very substantial number of additional donations. So it was possible to undertake, as well as more generalised improvement in recruitment initiatives, you could undertake exceptional strategic targeted appeals as well.
Yes, although the numbers that we were talking about in terms of lost donors of, a few 10,000, that could be made up without going to the extreme measures of a Gulf War.
Then can I ask you next just a little about plasmapheresis? You've said in your witness statement, if we just go back to it, WITN 6919001, page 19, sorry, page 18 we'll start with. So halfway down that page, paragraph 19.0 onwards, you've talked about the benefits of plasmapheresis having been really well established long before you were involved with the National Directorate. And 19.2, bottom of the page, you say that you believe, this is by 1989, scaled up machine plasmapheresis centres would have been very cost effective and cheaper than manual methods could have been. But then top of the next page, you observe 19.3, the National Directorate had no power to compel RTCs to do anything. We managed entirely through goodwill and consensus building. And then you described there being some RTCs which were pioneers of machine plasmapheresis, others had more difficulty. And then 19.4, the plasmapheresis programme self-evidently increased the supply of plasma. To what extent is this a fair comment? If there had been, significantly earlier than there was, a national body with the power of compulsion, so if a national blood authority or similar had been introduced, let's say, in the first half of the 1980s, with a power of compulsion, would it be fair to say a lot more could have been achieved in terms of plasmapheresis and increase of the blood supply, plasma supply?
I'm not sure, because the plasma supply isn't something that could be turned on and off like a tap. It had a natural speed, I think, at which extra donors could be recruited, and that the system could be built up. And I have included from 50 years of blood transfusion the graph showing the growth of the plasma supply. Now, whether that graph could have been much steeper, I actually doubt. It could all have been moved along a year, perhaps, but I don't think it could have been steeper. So I don't know what options this overarching authority that we're hypothesising would have had. It probably would have had to work on pretty much the same trajectory. And I think I've considered elsewhere that just supposing it had been a lot sharper earlier, a steeper trajectory earlier, then we would probably have had a huge stockpile of untested plasma that we wouldn't have been able to use anyway, given the way the HIV virus came in the middle of that period.
Untested by reference to HIV.
Yeah. I mean, Harold Gunsel always used to say that the plasma supply, the growth of the plasma supply is like a swan rising from the water. It takes a lot of shoveling, but then it gets there and it gains altitude, and that's what we did with the plasma supply. So however you do it, you've still got this shoveling around bit at the beginning.
Can I then just ask you just a couple of final topics? The first is in relation to transfusion practice, so the use of blood for transfusions. We saw reference a little while ago to that discussion at the National Management Committee about the establishment of regional transfusion committees, hospital transfusion committees. Leaving aside the issue about transfusion committees, did the National Directorate give consideration to introducing a national programme of education or training on minimising blood usage or reducing blood usage?
Not that I recall. That would have been something, as far as the transfusion service was concerned, it would have been for regional transfusion doctors to talk with the haematologists locally. Their haematologists would have quite likely been members of the Blood Transfusion Society, so there would have been colloquia on the topic. I mean, I think everybody in the service was well aware that one should minimise blood usage unless absolutely necessary. I mean, but I don't think that the National Directorate certainly didn't have, as far as I know, any initiative in that direction.
And then the other topic I just wanted to ask you about briefly is in relation to record keeping. If we go to your statement, I'll get the page in just a moment. Page 42. Now, you were asked here a number of questions about record keeping, which I think you said in your statement that you had difficulty in answering, I think, some of the questions that the inquiry had posed. So I'll perhaps approach it in a slightly different way. Did the National Directorate take any steps to try and, well, first of all, to audit the way in which records were maintained by individual regional transfusion centres?
Yeah, well, actually, since I wrote that paragraph in my witness statement, I was able to, one of the documents you sent me was guidelines for the blood transfusion services in the United Kingdom. That's NHBT 12345027030, and that does actually outline the quality system requirements, and under quality system requirement for record keeping, it says that records should be kept for 15 years. I didn't have access to that when I wrote this statement. So yes, it's in there in the quality system. It would have been audited. Clearly, I don't know that we could have seen whether they were prospectively going to be kept for 15 years, but yes, it is in there, and we would have audited it.
And then in question, or paragraph 64 of your statement, you referred, this is about 2/3 of the way down that paragraph, to each donation being barcoded so that a complete process history could be assembled for every donation. Do you know when the barcoding was introduced? One of the questions I've been asked to ask you.
I think there were several generations of barcoding. We were going to move to barcoding 1 to 8, I think, sometime in the late 80s. I think it was introduced probably in the early 80s. I could probably find that out and get back to you if it is of interest.
Thank you. And then what you describe in this paragraph is a requirement for comprehensive records for every aspect of blood collection and processing, and being able to assemble a complete process history. I don't know whether you can answer this, Dr. Moore, but again, it's another question I've been asked to ask you. Did the process history that you describe being required to be recorded extend past the issue by the regional transfusion centres to hospital blood banks of the product? Did it extend to following through what happened to the products in terms of individual patients?
I don't think so. I think our responsibility stopped at the issue to the hospital blood bank, but I think the hospital blood bank was supposed to keep records of who in the hospital it was issued to and which patient it went to. So I don't think they would have been transfusion records, but they should have been hospital records, and the two should have been able to tie up. I mean, the whole idea was that you should be able to link donor with patient.
And did the National Directorate ever, as far as you can recall, give consideration to taking any steps in relation to that to try and extend the process history beyond to the ultimate recipient?
I can't recall offhand, but I'm pretty sure that we would have advocated it. I mean, that was the whole concept of keeping records, was to link patient with donation. But I don't, whether it might be in the quality system if I read it more closely again.
Okay. Well, we can look at that too, thank you. And then you were asked we go to page 45, paragraph 75 of your statement. You've explained there that the national management system didn't collect information about individual donors. And you say, I understood RTC shared information between themselves about excluded donors, but I do not recall the protocols used. So, again, do we understand from that the National Directorate didn't itself take any steps, for example, to institute a national list of excluded donors?
Yeah, that's right, we didn't.
Now, if we go back to Dr. Gunson's 50 years of the blood transfusion service, NHBT 5028, and go please to page 85. We have a section on the demise of the National Directorate, and I just wanted to read a couple of the passages and then ask you for any observations you have. So the first paragraph under that heading refers to the publication of the white paper, Working for Patients, and that, I think, anticipates what you told us earlier about the National Health Service and Community Care Act 1990. And then it refers to the establishment of a financial subgroup, efforts to achieve a national costing system. And then it says, Doctors Gunson and Moore were concerned at this fragmentation of the service, which had the effect of marginalising the National Directorate. The lack of executive authority to implement national strategies was a major disadvantage. Successful initiatives such as quality assurance and the MIS, the Management Information System, could only be taken so far without a national strategy for capital and revenue investment. Agreement for such expenditure had to be given by 14 regions, and then further reference to the devolution of budgets. To bottom of that paragraph, without national management, it was difficult to put forward novel policies that would be acceptable to all RTCs, or to define savings which might help to pay for developments. And then, next paragraph, with the support of the NMC, that's the National Management Committee, and the majority of the RTDs, although some reluctantly, the advantages of a nationally managed service were put forward to the DOH. And then there's reference back to the 1987 management report and what was said about that option. And then if we go to the top of the next column, the request for a nationally managed service was turned down. Has to be recognised that at that time DOH policy was directed towards devolution. The creation of a special health authority to manage the MBTS had little appeal. And then there's reference to the National Directorate commissioning Ernst Young to consider organisational options, reference to a meeting in June 1991 of RTDs, favoured option, the establishment of a national blood authority, And then the next paragraph refers to the Department of Health issuing a consultative document in September 1991 in relation to that. And then we know that the National Blood Authority, I think, was announced in Parliament by Mr Sackville on the 27th of November 1992 and established in the spring of the following year, by which time you'd left. First of all, is there anything set out in the passages I've read from Dr Gunson's document that you disagree with, or does that accurately reflect your recollection and your views?
No, I think it's pretty fair.
And so, looking at that, looking back now with the benefit of hindsight, in your view, should there have been established at a stage earlier than it was a nationally managed service, including the financial responsibility resting with the service rather than with regional health authorities, at a significantly earlier stage than it was?
I'm not sure. There are pros and cons. I mean, if you go back to the first meeting of the MBTS Management Committee, you'll see that within 6 months we had got a steering group for the Management Information System. We had virtually sorted out the transfer of blood between regions, and we had a central system for the provision of donors. We had got a quality system. We were starting to look for courses for quality managers, all that within an incredibly short period of time. I don't think any other organisation could have done that. I think if we'd gone for something big like a special health authority, we would have spent a year and a half trying to get something together, and those things would not have happened as quickly as they did. So I think that interim option, get something there, get something happening, was probably the right one. And if you look at the reprise that is written here, it does actually say that there were a lot of benefits from the Directorate in terms of making things happen, helping the transfusion centres to work together far more closely than they had before, and then that led in an evolutionary way to something different or better, more centralised anyway, in the National Blood Authority. So I think it worked well in an evolutionary way. If it had happened earlier, it's hard to say at what point in time it would have given the same benefit. So I'm quite content, even with the benefit of hindsight, that it was a reasonable stepping stone towards a national service. And we should, of course, remember that when we went for that interim option, we didn't know about the purchase of provider split. That was kept under wraps and really sprung on the whole health service. So we had no idea that was down the line. And that was, as Dr. Gunson puts here, that really did have the effect of making it very, very difficult, marginalising us to some extent.
If one then leaves aside the question of what form a national body might take, so leave aside the question of whether it's an interim national directorate, a special health authority, or whatever it might be, the principle of there being a nationally managed, coordinated blood transfusion service. We've seen, I think, reference in the materials to a lot of advantages of having a nationally coordinated service as opposed to 14 individual regional health authorities and their regional transfusion centres. Were there ever any disadvantages to having a nationally coordinated service of some kind or other?
the advantages of a service, a nationally coordinated service, to my mind, are in terms of efficiency and cost effectiveness. It saves duplication of effort. I don't think there are advantages of national coordination in terms of product safety. And I think it would be wrong to read that because we didn't have a nationally managed service, somehow it led to less safe products. I think the products would have been as safe or as unsafe as they were, whether we'd had a nationally managed service or not. We would probably have saved money if it had been a nationally managed service, because as the NBA found when they started looking across the service, there was duplication, and in fact they were able to run down some centres completely because of that duplication. They found more efficient ways of doing it. So the national management, which was really what prompted the study in the first place, what was about efficiency, which is about doing the same for less money.
Can I just explore with you finally one example of where it might be said something coordinated nationally might have had a direct impact in relation to safety? We've heard in relation to the North London Blood Transfusion Centre, we've heard from Dr. Hewitt and from Professor Contreras, that in 1983, they introduced a number of initiatives, in 1983 and 1984, in relation to donor selection. So rather than simply wait for a leaflet, we know some centres introduced leaflets earlier rather than waiting for the Department of Health to produce one in 1983. And then specifically in relation to North London, they told us about individual initiatives, particular questionnaires that they considered introduced a more rigorous approach to excluding high-risk donors. Now, that's one regional transfusion centre, but if you'd had a nationally coordinated nationally coordinated service, wouldn't that provide the opportunity for the best practice, the above and beyond the lowest common denominator examples, to be considered and introduced on a national level, rather than it being left to the discretion of individual regional transfusion?
No, I like to think we did that. I mean, I like to think that we continued in the Directorate, we continued the same tradition of working groups in order to make sure that we did have best practice, and that best practice was incorporated in the Red Book. The issue that I think you're referring to about the medical selection of donors, I think is something that Dr. Gunson looked at in early '93 after I had left. But I don't think there would have been any inhibition in making sure that we did have the best available and share practice across the service.
So those are my questions, with some from call participants for Dr. Moore, but there may be a handful of further questions. So if I could ask for a further, perhaps 20 minutes or so to consider any further suggestions.
Yeah, yes, well, we'll do that and come back at 10 to 5, if we may. The purpose of this is that there are a number of core participants who are entitled to ask questions through council. Plainly, they're not currently in the room. That's for very good reason, but they are in contact and have been watching what you've had to say and listening. And if they have questions, it's right that council has an opportunity to put those questions to you. I don't know how long you will be when you come back, but perhaps it may not be for very long, but I can't promise. But thank you for your patience. And we'll take 20 minutes and come back at 10 to 5.
Thank you, sir.